afternoon to all. So happy to see you all. Today, as Sri Priya said, today we are going to learn about wound management. So there are a lot of nursing issues in palliative care, but this is one of the major one, wound management. You might have seen different types of wounds in your settings, but in palliative care, we have seen only two different types of wounds. One is pressure ulcer and the another one is cancer wound. So let me share my screen first. Hope my screen is visible to everyone. So as I mentioned earlier, there are two different types of wounds which we have seen in palliative care commonly. One is pressure ulcer and another one is fungating wound or cancer wound. So what is pressure ulcer? Can anyone say what is pressure ulcer? Any idea?
Good afternoon, ma'am. Can I answer?
Yes, ma'am.
Yeah, ma'am, pressure ulcers are ulcers which develop due to constant pressure over a particular area over a period of time, leading to decrease in blood circulation. Common example that we see is bed sores.
Yes, you are correct, ma'am. So pressure ulcer is a localized injury to the skin and other underlying tissue, usually over a bony prominence, as a result of prolonged unrelieved pressure. If there is a prolonged unrelieved pressure there is a chance of getting continuous pressure on, especially on the bony prominence. So then that leads to the patients will get pressure ulcer. So if there is an unrelieved pressure on that area, particular area, so it can occur anywhere. So based on the patient position, it can occur, but especially it will be on the bony prominence. So coming to the pathophysiology, so we all know that how the pressure ulcer can occur. So just imagine a patient lying on a bed for a long time. So what happened when a patient is lying on a bed long time? What happened? So usually, because of the body weight, the bone will be compressing to that person, to that hard portion, that backs that the mattress. That time, what happened? The tissues may not get adequate within if there is any lack of blood, that blood supply there, the tissues may not get adequate nutrition. So if there is the tissues not getting adequate nutrition, what happened? The tissue ischemia, stress and breakdown. So why I am telling this pathophysiology with you all is, within the hospital, we have nurses. Nurses will take care of the patients. When they go home, who will take care of the patient? The caregiver will take care of the patients. We need to educate the caregivers and the patients about the prevention of pressure ulcer. So we need to understand them, how the pressure ulcer can happen and what is the importance of position change and all. So coming to the risk factors, there are intrinsic factors and the extrinsic factors. This is the friction and shear is the extrinsic factors. So friction. So for a bed-bound patients, we need to change the bed sheets every day. But within the hospital, we have a nurses. Nurses will change the sheets. But when they go home, they need to change the sheets. But they don't know how to change it, how to remove it, remove the old sheets. And they usually pull the sheets under the patients. So that time, there is a chance of breakdown of skin between the frictions will happen there because of the sheets and body friction, that there is a chance of breakdown of skin. And the next thing is shear. So here, if there is, just imagine a obese patients, usually they slipping downwards the blood. So when we reback to their normal position, what happened? So we usually call that more people and forcefully we force the patients up. So that time there is a chance of that injury can happen in the deep tissue injury can happen. So if you want to pull the patients up, we have to take the patients with the help of a sheath. We can move the patients. Otherwise, it will affect the tissues. And now impaired sensory perception and impaired physical mobility. Here, so just imagine a paraplegic patients. They may not sense the lower part of the body. They are not able to move their upper limbs. But here, what happened? If they want to change the position, but they may not be able to turn independently. They need help always. So here, immobility can. Sorry. So immobility is another cause of pressure ulcer. And altered level of consciousness, either semi-conscious and unconscious patients can develop pressure ulcer, but they are not able to tell the caregivers because they are semi-comatose or unconscious patient. And fecal and urinary incontinence. Here, for a paraplegic patients also, if they are getting a spinal cord injury, they may not, urinary, fecal and urinary incontinence will be there. Here also, continuous moisture. There are three major causes of pressure ulcer. One is continuous pressure. The second thing is friction. The third one is moisture. So these are the three major causes of pressure ulcer. Here, friction and continuous unrelieved pressure, fecal and urinary incontinence can cause moisture, continuous moisture. So that patients can develop pressure ulcer and malnutrition. So if there is any lack of protein intake in their diet can cause pressure ulcer. Even if you change the position every 2 to 4 hours early and give pressure relieving mattress and all, then the patients will develop pressure ulcer, definitely maybe because of lack of nutrition and dehydration. If there is a dehydration there, it can affect the skin, and excessive body heat. And if there is a excessive body heat there, again moisture can happen, and then that leads to the patients will get pressure ulcer advanced stage. So these are the risk factors of pressure ulcer. Coming to the common sites, as I mentioned earlier, it can occur anywhere based on the patient position. It can occur on their body part. So especially on the bony prominence, but it can occur anywhere. Even if the patient is on wheelchair, also the patients can get pressure ulcer. So they need to change, they need to relieve the continuous pressure at least 15 to 20 minutes. So I'll come to later about how to relieve the pressure on a wheelchair patients and all. Here, so as I mentioned earlier, it can occur anywhere. From this picture, you can understand that. So heel, occiput, scapula, toes, sacrum, so all areas will be affecting, right? So these are the common areas. It can occur anywhere based on depends on the patient position. It can occur. So coming to the common sites, again, I'm mentioning about each position. I'm going to mention about the each position. This is one of the common positions which we have, which the position which normally the person lying down. This is a supine position. If the patient is on supine position, he also head, shoulders, elbows, buttock, heel, toes. These are the common that areas the patients can develop pressure ulcer. Why I am highlighting these points is we need to change the patient from the supine position to right lateral or left lateral position. We need to change the position. So whenever we change the position from supine to side lateral position, we need to give a special attention on that areas. Because if there is any color change there, we need to give a special attention on that area. We need to prevent further pressure on that area. So moving to the sideline position, either right lateral position or a left lateral position. So these are the important bony prominence, the patients can pressure points that the patients can get pressure ulcer. So when the patient is on sideline position, so there is a chance of the developing pressure sore in between the knees, because the knees will be rubbing together and that can cause friction. The friction might be there. So if there is a friction happen there, so that area will develop pressure ulcer. So always you have to keep a small pillow or a folded sheets in between the knees while when the patient is on the right lateral or left lateral position. Coming to the Fowler's position, we all know that this is the best position for the patients who is suffering with dyspnea, breathing difficulty. Patients can get relief with this position. Even if this position also, we need to give that position change, at least a 10-degree turn is mandatory. So we don't need to put the patient is in that supine position or right lateral or left lateral. At least you have to turn 10 degrees. So 10 degree, the pressure relieving, is mandatory for these patients also. Coming to the prone position, here also prone position, elbow, head, chin, chest, reproductive organs, knee, toes. These are the major bony the pressure points that patients can get pressure ulcer. So here, if the patient is having a huge sacral area pressure ulcer there, we put the patients like this position. So you have to sometimes if the third, fourth stage pressure ulcer there, we will do the skin grafting procedure. So before that, so after skin grafting procedure, they need to we need to keep the patients prone at least for 2 weeks. So before, if they are willing to do that procedure, if they are physically fit, we train the persons before that, so prone positions, whether they are able to tolerate this position and all. Even if you put the patient in prone position also, you have to check whether they have developed any color change or not. So if we have to give all special attention on that pressure areas. Coming to the stages of wound, there are 5 stages of wound. The first one is redness. This is the first stage. We usually call non-blanchable erythema. So non-blanchable erythema is the stage 1. If these changes there, this color change there, if you apply pressure, your finger pressure on that area, that redness will be there, not blanch. So that is called non-blanchable erythema. So in this stage, if you have seen this color change on that area, so you won't give further pressure on that area. That is the management of stage 1. So if you don't care on this stage 1, that skin will damage. The shallow open ulcer will be there. The dermis layer will be damaged, or blister formation will be there. If there is a blister formation there, definitely the skin will break down. The open ulcer will be there. So here is a clean wound, no pus formation, no slough. So you have to clean with normal saline. This is the second stage. You can clean with normal saline, and after that you can cover the wound properly. And coming to the third stage, full thickness ulcer. All subcutaneous layer will be affecting. Okay. So here full thickness ulcer and sometimes tunneling will be there. So tunneling, a narrow opening or passageway that can extend in any direction of the soft tissue. So this is tunneling. So if the wound has any tunneling, you have to check it. When you assess the wound, you have to check whether the wound is having any tunneling or not. If there is a tunneling there, you have to give special attention on that area. Otherwise, that wound won't be healed properly. And coming to the fourth stage, exposed muscle, bone, and tendon. So this is the fourth stage. You can able to see the bone, muscle, and tendon. So I'll come to the management later. The fifth stage is unstageable. So unstageable is if there is a black necrotic tissues on the top of the wound, we can't assess the wound. So that we call it as unstageable wound. So if you, when you document it, you have to document it is an unstageable wound. So we don't know how much depth is involved and all. So when we remove the black necrotic tissues from the top of the wound, then we understand that how much the involvement is there. Then we can able to confirm whether the wound has a third stage or fourth stage. So there are 5 stages of wound. One is pressure ulcer. The first one is non-blanchable erythema. The second stage is the dermis layer will be damaged, shallow open ulcer or dermis layer will be damaged. The third stage is a full thickness ulcer. All subcutaneous tissues will be affecting. The fourth stage is muscle, bone, and tendon will be affecting. The fifth stage is unstageable. So unstageable is if there is any black necrotic tissues on the top of the skin, we can't assess the stage, that is unstageable. So coming to the assessment part, so whenever you have seen these type of patients, even wheelchair patients or a bedbound patients, you have to do the proper assessment. So then only we can able to find out whether there is any maybe stage 1 pressure ulcer there. We need to give a special attention on that area. We can prevent further deterioration. So here, whenever you have seen these patients, what are the things you have to assess? Assess pressure points. First, you should assess the pressure points and then assess the pain associated with wound. If there is any wound there, you have to check with them whether they have any pain. So because we all know that pain is what the patient says hurts, and pain is a subjective experience, we need to believe the patient words. So always try to talk to them and assess them whether they have to ask them whether they have any pain or not. So if they have pain, you have to give some analgesics before that, and then you can do the pain management. And then assess the location of the wound, measure width, length, and depth. You so approximate measure that you can imagine approximate width, length, and depth, and then you can document it. Stages of wound and presence of exudate. Exudate is oozing out a fluid or a purulent discharge from the wound. Assess for tunneling, and all those things you have to document it properly, because we need to cross check after 2 weeks or maybe 1 week whether your treatment is effective or not, and also your colleague will be benefited for that. Maybe next time that your friends will be seeing that patients, they will get an idea about the condition of the previous wound. So then they can able to differentiate okay, whether there is any improvement happen after treatment and all. If there is no improvement, we can think about to change the treatment regimen also. Coming to the management, as I said earlier, always medicate the patient pain before wound care. If they have pain, you have to give some analgesics before that, and then you have to do the wound management. So stage 1 pressure ulcer, that is non-blanchable erythema, there you have to teach the caregivers about the turning techniques and the incontinence control. So as I mentioned earlier, moisture, continuous moisture is also a cause of pressure ulcer. If they have a stage 1 pressure ulcer, they need to give they need to prevent further pressure on that area and also prevent moisture. If they have if there is a incontinence there, they need to change the sheets as soon as possible. Always then if they are willing to put a catheter, you can advise the patient to put a catheter also. That way we can able to manage. So coming to the stage 2, only the clean ulcer, the dermis layer will be damaged. So you can clean with normal saline and you can do the dressings. You can cover the area with the dressing pads. I'm coming to the third, fourth, and unstageable wound. If there is a black necrotic tissue there, you can do the surgical debridement. And use normal saline. Always you have to use normal saline for wound cleaning. And if there is any odor or infection there, you can apply metronidazole. So metronidazole is one of the good agent for controlling anaerobic bacterial infections. You can use metronidazole. If there is a nowadays the study says moisture is one of the good thing for wound healing. So we usually what we do here is we take a metronidazole tablet and crush it, make it a powdered form and mix with white petroleum jelly and make it a pasted form and then apply on that wound. So that time the wound will get two things. The metronidazole will give antibiotic effect and the white petroleum jelly will give a moisturizing effect to the wound. So, so this is the one method of management. And the another one is debridase ointment. So this is quite expensive, but if there is a after slough cutting, if there is a slough there, you can apply debridase ointment. So after, see if there is no slough in the wound, then you can apply mega heal. So here, this is expensive. If the patient is affordable, you can suggest. Again, the management, if there is a bad odor there, you can apply charcoal dressings. But the thing is too expensive. They are affordable. You can suggest charcoal dressings, but otherwise you can take charcoal pieces. You can easily make it in your own in your home. So you can tell the patients they can able to make it in their home charcoal, so that this charcoal is the good agent for absorbing bad smell. So this is the you can suggest if there is a bad smell there, especially stage 4 pressure ulcer there is a chance of bad smell. So that time you can suggest. And always here we don't use hypochlorite solutions like povidone iodine and hydrogen peroxide solution. If you use povidone iodine and hydrogen peroxide solution into the wound, what happened? Any answers?
Worsening, excuse me, ma'am, can I answer?
Yes, ma'am.
Ma'am, probably there will be worsening of ulcer because of because they produce effervescence and peeling. Actually, povidone iodine releases iodine and hydrogen peroxide releases nascent oxygen. Both of them cause effervescence. So that may actually cause more damage in these cases.
Yeah. So actually, as ma'am said, this will destroy the granulation tissues. So, so you can use normal saline for cleaning. So normal saline is enough for wound cleaning. So, and then a surgery consultation. If there is a 4th stage pressure ulcer there, you can think about if the patient's health condition is okay, then you can think about the skin grafting procedure. Also, you can refer the patient to the surgeon and find out whether there is any skin grafting procedures that possible or not. If they are able to do it, or you can support, then if they are fit for the surgery, you can do it. That way we can able to manage. And finally, negative pressure wound therapy is also there. So you can, with the help of negative pressure wound therapy, that all with the continuous vacuum pressure, continuous pressure, that time the all exudates will come out easily, and the frequent vibration can cause the wound will get continuous stimulation and improve the circulation, and that way they can able to heal the wound properly. And if there is this is quite expensive, if you don't have a negative pressure wound therapy machine there, with the help of suction apparatus, we can do it. And coming to the dressing supplies and homemade saline, always within the hospital, we have a normal saline bottle and all. When they go home, so they need to buy it. If they sometimes they will not be able to buy it from the outside the pharmacy. So that time you have to teach some home remedies, because this is a clean wound. This is not a surgical wound. This is a clean wound. Clean saline is enough. So they can take 500 ml of water and add 1 teaspoon of salt and boil it and cool it. That then they can, that's normal saline, homemade saline. They can use for cleaning the wound. Here, and also you can teach some home remedies of dressing supplies also. So always the palliative care team will be providing dressing materials, but if the dressing material is finished, what they will do? You have to teach some home remedies also. Here they can take cotton sarees or dhotis and they can take clean. So after cleaning, they should take the sarees and dhotis and cut them into squares and then steam it. With the help of idli cooker, they can steam it. So if they need to that apply, they want to, the dressings are adherents to the wound. So if they want to that apply Vaseline on the wound, they can, before steaming, they can apply Vaseline on the gauze piece and steam it. Then they can take it before touching the dressings. They need to wash their hands with soap and water. That is the important message you need to tell the caregivers before doing the wound management. So we all know that prevention is better than cure. Always try to prevent pressure ulcer. Whenever you have seen a bed-bound patient, you have to teach the caregivers and patient about how to prevent pressure ulcer. Here, position change every 2 to 3 hours. For a bed-bound patients, we need to change the position. And if the patient is on that wheelchair, they need to relieve the pressure every 15 to 20 minutes. We have a video on that. I'll show you later. So then you will understand how to how to relieve the pressure on a wheelchair patient. And now manage incontinence. Here, if there is an incontinence there, if they are willing to put catheter, you can insert a catheter. Otherwise, they can manage with diaper. If they are not affordable, they can use their own clothes. And the thing is, if there is any wet or incontinence there, incontinence of motion or stool there, as soon as possible, they need to change it. And you can suggest some special mattress like air mattress or water mattress you can suggest. So here air mattress need electricity, water mattress does not need any that electricity. But the thing is, the air mattress is the good one. Here there is a 2 compartment. One is at a time, alternate compartment will be inflating, and the when the inflated one start deflating, that deflated one start inflating. The alternate pressure relievings will be there, but the thinking in between that creases, there is no pressure change. When the patient is, even if you advise, so they can use air mattress or water mattress. So you have to give a special advice. Even if the patient is on air mattress or water mattress, they need to change the position. So this is not 100% prevent the, we don't have any evidence for 100% prevention of pressure ulcer on air mattress, because in between the creases, the patients get continuous pressure. That patients will develop pressure ulcer on that area. They need to change the position, because if you suggest air mattress or water mattress for these patients, the caregiver might be thinking like, okay, this mattress will take care of everything. So they leave the patients always the same position there. So maybe after 2 to 3 days, the patients will get pressure ulcer. And also you can suggest some pillows and cushions under the bony prominence. And nutrition, hydration, exercise. Here, this is also important. So make sure that the patients can get adequate protein intake in their diet, and hydration, exercise. If they are able to do it, they can you can encourage the patient to do the exercise. But if they are not able to do it, you have to encourage the caregivers to do the that exercise. At least passive exercise can improve the circulation. That way we can able to prevent pressure ulcer. And massage. Whenever we change the position from change the patient from supine to side laying position, or side laying to supine position, side laying to prone position, you have to give a special attention on that area and apply give good massage on that area. So because you can use simple moisturizing cream. If there is no moisturizing cream there, you can use coconut oil. So our aim is to improve the circulation of that area. If you do the good massage on that area, then we can able to prevent pressure ulcer. And always you have to provide a wrinkle-free bed and give a good nail care too. So if their nails become short, that long, so that the thing is that nails will scratch on their own skin, and then that area, if you apply continuous pressure on that area, again the patients will get pressure ulcer. So you can keep it in mind always whenever you have seen a patient, bed-bound patients, double SKIN. The first S is supporting surface. Always you have to think about the supporting surface. You can suggest air mattress, or if the patient is on lying on a hard bed, you can suggest air mattress or water mattress and air cushions, or whatever it is you can suggest. And the second S is skin inspection. Whenever you have changed the patient from a that supine position to side lateral position, or side lateral to left lateral position, so you have to give a special attention on the pressure points. And K is keep moving. Every 2 to 3 hours you have to change the position. And I is incontinence or moisture control. So here, if there is a incontinence of urine there, you can suggest that police advise the patient to put a catheter. So if they are not willing to do it, then you can advise them to use a diaper, or they can use their own sheets. And the next thing is nutrition. And nutrition and hydration is also important. So always you can keep it in mind, double SKIN when you whenever you have seen a bed-bound patient. And engage the patient and family. This is also very, very important. We usually use the word. So we usually use the word you. So without the caregiver support, we can't do anything. So we need to educate the caregivers and empower the caregivers about the patient care. So here, how to engage the patient. So we need to develop a contact with the patient's care. So this is very, very important. We always use the term you. You should do like this. You should turn the patients. You should apply massage. You should apply moisturizing cream. You should do massage whenever you turn the patients. But instead of you can start use the word we. If you use the term we, they might be thinking like so somebody is there to hear their worries, and someone behind them to help them, and that kind of feelings will be there. So always you can think like that, and address them the word we. So that time we can able to make a good rapport with them, and if they have any doubts or any clarification needed, definitely they will ask you. And also you can after the instructions, and if possible you can do the demonstration also. So if you as I discussed earlier, for a bed-bound patient, we need to change the sheets, but they don't know how to change the sheets. Instead of instruct the patients, at least you can able to show them at least once. This is how we change we need to change, turn the patient first, and push the loosen the old sheets and push the sheets toward the patient side, and spread the new sheets at that time, and turn the patients. So that way they we can, if possible, you can demonstrate them, and then they can able to follow. And also they can you can give some leaflets, like this is the information leaflets, because if they have any doubt, they can go and look into it. They can, based on this, they can follow. We have a video on how to prevent pressure ulcer. We'll watch on it, and then we can see the next part. So hope you have an idea about how to prevent pressure ulcer from that video. So I am going to the next part, that is on fungating wound or a cancer wound. So I would like to hear from you before I am moving to the fungating wound. So one question: what are the major difference between the pressure ulcer and the fungating wound? So you can unmute your and talk, or you can put your answers in the chat box. What is the major difference? There are difference. So what is the major difference between the pressure ulcer and the fungating or a cancer wound? Any idea?
Not necessarily on the pressure points, actually. Fungating ulcers are not necessarily on the pressure points. On the other hand, pressure sores are mainly in the pressure points. Actually, they're infected. The fungating wounds are generally infected and with lot of slough.
Okay. Thank you, ma'am. Thank you for your answers. Any other answers? So, okay, stay with the ma'am said pressure ulcer will be at the pressure points, fungating wound will be on the tumor. Okay, any other answers?
Fungating wounds are protruding and those are punched in, like pressure ulcers are punched.
Okay, fungating wounds are protruding out. So the pressure ulcer is deep into the tissues. Okay, then any other answers? Okay, thank you for your points. So you all are correct. So here, pressure ulcer can be prevented and curable. So pressure ulcer is preventable and curable, and this is not preventable and not curable. So this is the major difference. And all that others also other answers also correct, but this is one of the major difference. Pressure ulcer is preventable and curable, but the cancer wound is not preventable and not curable. So let's see what is fungating wound. It is a primary or a secondary malignant growth in the skin which was ulcerated and difficult to heal. So here it is the proliferation and that ulceration proliferative growth will be happening at the same time. The lot of necrotic tissues will be there, and it looked like a nodular fungus in shape. That is why we call it as fungating wound, that not because of fungus. So it looked like a nodulous fungus shape, and also it looked like a cauliflower in shape. So here this is a cancer wound. So pathophysiology. Here we all know that there is a development of non-tender skin, that skin nodules. Gradually the skin nodules will be enlarging. So if there is a skin nodules enlarging, what happened? That leads to disruption of capillaries, and lymph vessels will be there. Then altered coagulation, finally tissue hypoxia and necrosis. So this is the pathophysiology of pressure ulcer. So now, so how many of you have seen Marjolin ulcer? What is Marjolin ulcer? Any idea? So Marjolin ulcer is a type of malignancy of the skin. Malignant changes in the chronic wound. That example, burn scar ulcer and pressure ulcer, venous leg ulcer. So that the pathophysiology is quite different. Here, appearance of mass in the wound not previously present. So you might be thinking like there is a granulation tissues, but the thing is the patients might have developed that pain and the changes of that character, volume, and appearance of wound will be there. So if these changes will be there, you can refer the patient to the oncologist and see whether they have any Marjolin ulcer. This is the curative possible cancer. If these changes there, you can refer the patient to the oncologist and find out whether they have a Marjolin ulcer or not. So coming to the problems, this is the non-healing ulcer. We from the beginning we understand that class. What is palliative care? Palliative care is a total care. It's not only for the patients, it's for the family. So we need to give a 4 aspects care for these patients: physical aspects, psychological aspects, social aspects, and spiritual aspects. Here, let's see what are the physical problems. Just imagine a patient on a growth on their face, a fungating wound on their face. So what are the physical problems can happen that patients? So here, pain, malodor, bleeding, exudate, itching. So these are the sometimes infestation with maggots, communication difficulties. So pain, so sometimes the patients can get 2 different types of pain: nociceptive pain and neuropathic pain, because the tumor will be pressing the nerves or blood vessels. That time the patients will get neuropathic pain, that may be like a burning type of pain and all. Sometimes allodynia will be there. So, and direct exposure of dermis can cause nociceptive pain and malodor, because sometimes the stale X-ray dressings have been more than number of days can cause malodor. And the another thing is that lot of necrotic tissues. So here, because of the anaerobic bacterial infection produces lot of because of the necrotic tissues can cause bad smell and bleeding. Sometimes you usually heard in cancers, sometimes the tumor will be protruding the major blood vessels. So that time bleeding can happen, and also the dressings are adherent to the wound. So before removing, we need to soak the dressings with normal saline or normal water. So if you are not soaked well, if you try to remove the dressings, old dressings from the wound, there might be the chance of developing bleeding and pain also. Itching sometimes there. So because there is a new that nodules begins the sides of the wound, that time the chemical reactions will be there. That time the patients feel itching, and also the exudates will leak out the normal skin, can cause the patient's itching and infestation with maggots. How does maggots come? Any idea? How does maggots come? Any answers? How does maggots come? So Kanmani ma'am said exposure to flies. How many of you agree with that?
I think it is due to deposition of
Uh,
eggs in the.
Poor hygiene. Then any other answers?
Due to deposition egg.
Okay. So thank you for your answers. It comes from house flies. Usually the house flies are attracted with the infected wounds. When they touch the wound, they may lay eggs. Within 8 to 12 hours, they come out of maggots. So always tell the patients about the proper covering of the wound. They don't know how does maggots come. We need to educate the patients about the prevention of maggots also, and communication difficulties. If they have a communication difficulties, example, head and neck cancers, they won't be able to communicate their problems freely. So better you can do one thing. If they are able to write down their problem, you can give a sheet of paper and ask them to write down their problems. That way we can able to manage. And so coming to the psychological problems, altered body image. So this is a major problem. Here we always, if we have a small, maybe the big pimple on our face, if we get a chance to see the mirror, so we will go there and see whether the size is increasing, decreasing, that if whether there is any color change there, that kind of things thinking inside our mind always. So here, this is a non-healing ulcer, that proliferation will be there, the tumor will be protruding out, there are a lot of problems. So altered body image is one of the most that psychological problems that patients can get. And sexuality will be affecting because the misconception of disease, denial will be there. Sometimes the patient may not accept the truth. So if the wound will be proliferating fast, but sometimes the patients will tell you like, no, doctor, my wound size is decreasing. Is it? Isn't it? That kind of that thinking will be, that questioning will be there. So that time, what you can do is you can listen. You don't take it as a challenge and make them understand. No, your wound is not going to heal. That kind of things you won't tell. You can listen that thing, that problems that time. So, and if they are telling like, if that wound size is increasing, that might be they will tell like, oh, my wound size is decreasing. You can listen and they will gradually accept. And they will, maybe after 2 or 3 weeks, they will come to you and tell you like, oh, my wound size is increasing, right, ma'am. Sir, that kind of answers will be there. So you won't take it as a challenge and make them understand that time. And fear will be there. So what is next? And depression, anxiety. So the day by day, the problems will be increasing. The family members will that affecting because of the laughter problem, because malodor, exudate, and all will be affecting the family members. And also, so here the patients will anxious about the next the days and all. And gradually, if the physical problem is not controlled well, the patients will go to depression, and shame, guilt feeling will be there. And here social family isolation. Sometimes the family will choose a corner side room and keep the patients there. So that will be affect the patient emotionally. And social isolation, nobody is willing to see the patients. That these kind of patients, maybe neighbors not want to see this patient, maybe relatives not want to see this patient. Maybe sometimes they might be because of misconception of disease and social stigma, fear of contagion, effects on family will be affecting, and effect on sexual relationship and marital disharmony, because nobody is willing to get married from this family because of the hereditary factors and all. So these all things will be affecting the patient emotionally. Because of me, my daughter doesn't get married because of me only. So that kind of thinking will be there. And coming to the spiritual interference with the religious, right? Because of my sin, God punished me like this. These kind of things will be there. So what you can do is, when you do the assessment, you have to listen. If possible, you have to do the individual assessment. One thing you have to keep it in mind. So in front of the caregivers, they won't tell the truth. So they always hide the truth, because nobody is accept that maybe the patients, they will keep the patient in the corner side room, and they won't allow to enter the kitchen, and also they won't touch the wound, they won't take anything from that patient. That kind of thing will be there. Even in front of the caregivers, they might be telling like, okay, she will take care of me very well, like that kind of things. So if you do the individual assessment, they will tell the truth. Whenever do the assessment, you have to do the wound location, wound appearance, surrounding skin, and potential for complications. If there is a head and neck cancers, you have to educate the family members and prepare the family members about how to how to manage if there is a profuse bleeding there. That kind of thinking will be there. So you have to do the proper assessment. Coming to the principles of management, we all know in palliative care, we all try to relieve the symptoms. If you are able to relieve the symptoms, we can able to improve the quality of life of the patients. Here, palliation of symptoms, always if they have pain, you can try to relieve their pain. And if there is, if they have a water, you can control their infection and manage, try to control exudates and minimize bleeding. Holistic care is here, is this patient is need total care, 4 aspects care. Empowering patient and family, family in wound care. We need to be so every day we don't know, we are not able to go their house and do the dressings, but you can train the caregivers too. Our criteria for wound dressing is, our goal is to maintain or improve the quality of life of the patient through symptom control. And always you can do the empathetic care to the patients. We don't want sympathy. We need an empathetical mind to treat these patients. If possible, you can ask the patient to take a thorough bath, because if they are able to take a thorough bath, all necrotic tissues will fall off. So without applying your pressures, all necrotic tissues will fall down. So if they are okay to do it, you can encourage them to take a bath. And as I mentioned earlier, you have to make sure that whether the patient is pain-free or not. If they have pain, you have to give some analgesics before that. Here also normal saline, you can take homemade saline for cleaning the wound. Select dressings based on depends on the wound size and the drainage of that exudate, that level of the exudate. So you can select the dressings. Coming to the pain management, if they have a deep pain, you can adjust the systemic analgesics. Example, if they have a morphine, 10 milligram for hourly, in between the patients might develop breakthrough pain, maybe before dressings, if they tell you like, I have a pain like that, you can give a same dose of breakthrough, the same dose for breakthrough pain, and after half an hour to 45 minutes, they will get a pain relief. Then you can do the dressings. And if they have a superficial pain like burning, pricking type of pain there, your systemic analgesics may not work. That time you can apply local application. You can apply sensorcaine or silocaine. So then within 2 to 10 minutes, the patients will get local anesthetic agent effect to that wound. Then you can able to do the dressings. Coming to the malodor management, here also you can clean with normal saline, daily cleaning. So is mandatory, and apply metronidazole. Local, you can take a metronidazole powder and crush it, make it a powdered form and apply on that area. And so here is one of the metronidazole is one of the good agent for drug of choice of controlling anaerobic bacterial infection is metronidazole. So you can use injection metronidazole for irrigation, for cleaning, because there are a lot of pocket formation inside the wound. If you clean the wound with injection metronidazole, the injection metronidazole will go inside, and will get good effect. Maybe it will help to prevent infection. And also you can try a systemic antibiotics, because the superficially the blood vessels not fully that well, that you can try one course of antibiotics, and the frequent change of dressings depends on the exudate level. And here also no hydrogen peroxide and betadine. Bleeding, always try to prevent, because always the dressings are adherents to the wound. Before removing the old dressings, you have to soak with normal saline and or normal water. Then you can try to remove the old dressings. If they have a bleeding on the wound, you can tell them to give a local pressure. If that bleeding is not controlled, you can apply sucralfate powder, the same drug which we have used for a peptic ulcer, that will help to control the bleeding. And a tranexamic acid also you can use, and if not help, you can go for a systemic ethamsulate. And palliative radiotherapies also you can suggest, that will help to strengthen the tumor, size of the tumor. That way we can able to prevent bleeding. And always tell the caregivers about the dark color cloth. If there is a profuse bleeding there, So they wipe the blood with the dark color cloth, because the patient and family will, the relatives will be panic, and so we can able to, if they are do it like this, we can able to reduce the anxiety of the patient and the family members. And here role of cancer therapy is radiotherapy, cytotoxic chemotherapy, and hormone therapy, and surgery. Debulk surgery is also so advisable, and if the health condition is okay. So these all things, the radiotherapy, the cytotoxic chemotherapy, and hormone therapy, so if you do it, that will help to strengthen the size of the tumor. That way we can able to prevent bleeding. Coming to the maggots, if they have a maggots, so always try to prevent maggots. Always educate the patient about the covering of the wound properly. So it come from flies. So if there are maggots there, you can use turpentine oil for removing the maggots. You can soak the gauze piece and keep close to the wound, not directly pour to the wound. It will irritate the wound and skin, and it will irritate the patient also, because especially head and neck cancers, the breathing distress will be there. So always soak the gauze piece with turpentine and keep close to the wound. That time the wound will, the maggots will come out. You can take it out with the help of an artery forceps. The one important message I want to convey with you all is, don't follow maggots. So when they come out, when you go with your artery forceps, they go inside. There are a lot of pocket formation inside, so they will go inside and keep safe there. So because if you follow maggots, your artery forceps will damage the blood vessels. So when they go the come out, you can take it out. Don't follow maggots. Okay. So always educate the patient about the prevention of maggots. Thank you. Anybody have any doubts? Please ask. So otherwise, we can move on to the case presentation. So if you have any doubts in there, please put it in the chat box. Then we will, after the case presentation, we will discuss. Dr. Roshni?
Hello.
Yes, ma'am.
Yeah, audible. Thank you for the wonderful presentation, Sheeba ma'am. It was very useful, and good afternoon, all of you all. I'm doing a presentation on wound management. I'm Dr. Roshni. I'm presently working in MES Dental College. Can I have the next slide, please? Thank you. Today I'm presenting a patient whose age is 40 years. He's a male patient. The diagnosis is a pressure ulcer in the sacral region, which is a grade 2. Next slide, please. And the presenting complaint is, the patient complains of a wound in the back region since 3 weeks. History of presenting illness is, patient had undergone a surgery for spine problem 2 months back from a hospital. After getting discharged from the hospital, he was on bed rest. He developed a pain initially in the sacral region, which was red in color. Later, it is developed as a wound since 3 weeks. The pain described is a throbbing type. He had shown to a primary health center close to his house few days back, and he was given medicines. Patient had temporary relief of pain. At present, the wound is present and it is painful. On examination, the patient is moderately nourished and built, conscious and well-oriented, no signs of anemia, clubbing and jaundice, temperature non-febrile, pulse is 76 per minute, BP is 120/80, respiratory rate is 80. And on examination of the wound is seen in the midline of the sacral region, measuring 2 into 3 centimeters. The wound appears red in color, which is shallow. Wound is moist. The surrounding area also appears red in color, irregular in shape. The surrounding skin is warm on palpation. Next slide, please. On significant investigations and treatment, blood investigations, HB was 12, TC 36,000. You can see the polymorphs 75%, lymphocytes 20%, and eosinophils were 5%. Platelets were 2.5 lakhs per microliter. And wound swab was done for culture and sensitivity. And the psychosocial aspects for this patient is a 40-year-old male patient who's married and living with his wife and 2 children. He is a plumber and his family is depending upon him financially. Both the children are school-going age. The financial support at present is coming from his relatives, which is barely covering his expenses. And so the family is finding a difficulty in covering the expense of the medicine and to the visit to the hospital. So the main concern is also providing education for their children. Next slide. Medication is primarily, it is basically to remove all the pressure from the wound area by regularly changing the position, and specially designed foam mattress can be given, and keeping the wound clean and dry, and maintaining diet high in proteins and vitamins, proper hydration of the patient, cleaning the wound with salt water, and the wound has to be covered with a moist gauze. That's it. But the main concern is, the patient's main concern is pain and wound, which is not healing, unable to walk without support, and financial problems. So summary is, it's a 40-year-old man with stage 2 bed sore on the sacral region with pain. So the discussion point for today is, does the patient need a palliative care? Any psychological support for his wife? Any financial support can be provided for education of his children and other expenses, physiotherapy for the patient, and any other measures to improve the quality of life. Next slide, please. Okay, thank you.
Thank you, ma'am, for the excellent presentation. Anybody need any more clarification regarding this patient story? Please ask, ma'am. So otherwise, we can move on to the discussion points. Anybody need any more clarification? So I hope this presentation is clear to everyone. The first question is palliative care for this. Does this patient needs palliative care? What is your answer? So I'd like to expect from you, you have to answer, and you have to give some suggestions to Roshni ma'am for this patient care. So you have to contribute your things for this patient. Any suggestions? So what do you think? This patient need palliative care? So Amrita ma'am said yes. Jinsi ma'am said yes. Okay. So yes, definitely this patient need palliative care, right? So this is a bed-bound patient. So always depend on others. So he got a life-limiting illness. So this patient need palliative care. So we all agree this patient needs palliative care. Then the next question is psychological support. So how will you give psychological support his wife? My first question is, does she needs any psychological support? Okay. Okay. So Vandana ma'am, Girija ma'am, Lakshmi ma'am all said yes. Okay. So definitely this patient needs psychological support, because if a person get illness, if a normal person, maybe in our family also, if a person get illness and admitted in the hospital, that whole family will be affecting, right? Because even if we get out of we know we are able to do the normal work after 2 or 3 weeks, maybe after the curative treatment. So here is a life-limiting illness that family will be affecting. Not only the short period, it's a long period. The family, the wife will be affecting a lot, because the patient is bedbound, and the family, the caregiver will take care of everything, because his wife need to take care of the patient, and also she needs to take care of the family. So she needs a good psychological support, because my experience, my last 18 years of experience, if you go with a when I see a I always remember one patient, one bedbound patients. After seeing that patients, we come out from the room, and I asked her, so how are you? Is there any problem? So then she start crying, because nobody is asking her till that day, what is there any problem her. So always the relatives and neighbors will come there and neglect her always. Sometimes they blame her, so they always neglect and blame her, though you should do more that other things too. That kind of blamings will be there. Nobody is asking her problems. So here this is very, very important. You have to be understand that palliative care is not only for the patients, it's for the family. Without family support, we can't do anything. And also, if the caregiver is well, the caregiver will be able to take care of the patient. So here we need to protect the family members, and we need to take care of the caregivers also. So here what you can do is, if they have a psychosocial problem there, better you can try to include a medical social workers in that team. So here we need a teamwork. So here this patient need a physiotherapy, and also this patient and family needs have a lot of psychosocial issues. We need to explore psychosocial issues. So try to include a medical social workers in that team, so that way we can able to have that maybe take more problems, and based on the problems, once we elicit that problems, we can able to support them. So here you can try to involve the medical social workers. Definitely this patient need the caregivers, and patient need psychological support. Okay, then the third question is, any financial support can be provided for education for children and other expenses? What do you suggest? I would like to hear from you. Any answers? No answers? Yes. We have a project running. Okay. Okay. So here, Amrita ma'am said they don't have a project running in their organization about the family members and for their education. Here also in Pallium India, if the children's they may be lost, there maybe they are not able to continue their study because of the parents' illness, we will get the donors, and we will continue their educations. We will give support and continue the educations. That we have around 500 children in Pallium India, we will support. So here what you can do is, if there is a nearby NGOs which these kind of activities doing that NGOs there, you can connect with them. So through that, that the children will get educational support. No, so here we always think about the vocational rehabilitation, physical rehabilitation, educational rehabilitation, and all. So we need to think about the patient, the care, the income. So they need an income to live. No, so we can think about the wife. If his wife can able to do something, you can empower the wife to do that some kind of things, and where maybe out of that some few amount will get, and that way we can able to help them. Always think about the occasional rehabilitation, and physiotherapy for that patient is also important. Here you can if possible, you can try to include a physiotherapist. So if physiotherapist can maybe if you do the proper physiotherapy for these patients, definitely the wound healing also better will be better. So here try to include the all team. So here the teamwork is important. Nursing support will be should be there, and doctors need to give support, and physiotherapists and psychologists. So and if the local volunteers there, you can try to include the local volunteer supports, volunteer groups also. The volunteers will go there and support the family. Okay, at least one day they could help the family to change the sheets, and they change the patient dress and all. So that kind of help they can do. So they can do for that patient and the family. So that way we can able to give some sort of relief to the patient family. So is there any other measures to improve the quality of life of this patient? Any other suggestions from today's class? Any other points you want to mention, you want to suggest, or from your experience you want to suggest anything? Okay, ma'am, any other points you want to ask? Here you already doing all the things. So better if they are affordable, you can, what kind of dressings you have given?
Moist type of
Moist.
dressings.
What ointments you?
At present, no oilments, just a moist dressing is given. No oilments, no medications, no active medication, just moist dressing with gel, with Vaseline gel. Just moist dressings are given because there is no infection in the wound.
Okay, ma'am. So if there is a deep, the wound is deep, you can apply debridise, that Mecacil ointment, not a debridise. If there is no that slough, debridise is not needed. So you can apply Mecacil ointment. So that will help to heal the wound fast. Only superficial clean wound is there, no need. Only normal saline, but this is a little bit deep, right?
Grade
Yeah.
2.
Yeah, grade 2. So if there is this only peeling of skin there, no need. You can clean with normal saline and cover the wound properly. You don't give a further pressure on that area. We always think about the further deterioration of the other parts. Okay, so not only this part, the patients might have developed other pressures are on the other areas too. So we always prevent the further deterioration too. So here, if there is a only peeling there, you can leave it like that. You can clean with normal saline. Normal saline is enough. So if there is a deep injury there, maybe you can apply Mecacil. Otherwise, normal saline is enough, ma'am.
Okay.
So here, surgical intervention perform what? Swati ma'am said. So getting a comprehensive summary of the nature of this disease, surgical intervention performed, prognosis, need for reviews, etc. to be discussed with neurosurgery team, and the better to provide palliative care treatment. Yes. So here we already discussed here this patient no need of surgical intervention. Here is the stage 2 pressure ulcer. Here that normal saline with cleaning with normal saline is enough. And also the patient family needs good support, and the patient children need educational supports. So that kind of things we need to think about. So always you have to try to cover the 4 aspects: physical parts, social parts, psychological parts, and spiritual support. This, if they have a problem there, you can support as well. So this patient and family have lot of psychosocial issues. If they have a psychosocial issues, definitely the physical distress will be increasing. So try to solve their psychosocial problems. That way we can able to improve the quality of life of the patient. Okay, thank you.
Thank you, Sister Sheeba, for that wonderful session, and thank you, Dr. Roshni, for that very apt case presentation as well. Do we have any other inputs from any of the participants before we wind up for the day? If no one has anything else to share, maybe Sister Sheeba, with your permission, we can wind up for the day. Thank you, everyone. Thank you so much for joining in. And with a very positive note, this is Sri Priya, along with Sister Sheeba, signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care. Be happy. Bye-bye.
Thank you.